Welcome to another episode of Surgery from SnazzySurgeon.
Yeah.
Today, we're going deep into the world of inguinal hernia repair. As surgeons, we all see these pretty frequently, right?
Yeah, for sure.
But have you ever stopped to think about all the different ways we've learned to fix them over the years?
It's pretty amazing when you think about it.
It really is.
How we've gone from just using tissue to now using mesh and even doing these minimally invasive techniques.
It's like a whole evolution of surgical approaches,
Absolutely.
all aimed at getting those recurrence rates as close to zero as possible.
Exactly.
So, to kick things off, let's go back to the basics.
Okay, sounds good.
Way back to the late 1800s, with that foundational open tissue repair, the Bassini.
Bassini, the classic.
1887, to be exact.
The one that started it all.
It's all about approximating the conjoined tendon, right?
Right, bringing that internal oblique and transverse abdominis together.
Up to the inguinal ligament.
Using those interrupted silk sutures.
Seems simple enough in theory.
It is, in a way.
But you know what's interesting?
What's that?
Even back then, there were variations.
Oh, there are always variations.
Some surgeons were all about opening up the fascia transversalis,
To get a really good, tight approximation.
while others thought it was better to leave it alone.
It's fascinating how even the early techniques had different schools of thought.
It shows that surgeons have always been looking for ways to improve, even back then.
Absolutely.
And then, of course, we can't forget about Tanner's slide.
Yes, Tanner's slide.
That clever little trick to help with tension.
A simple but effective way to reduce strain on the repair.
For those who might not remember.
It's basically a vertical or sometimes curvilinear incision,
In the anterior rectus sheath,
and it's all about releasing that rectus muscle.
so that the conjoined muscles can relax and slide medially,
Exactly.
relieving the pull on that suture line.
It's like giving those muscles a bit of breathing room.
It was pretty ingenious for its time,
It was.
though we don't really use it that much anymore.
Not really.
It's more of a historical curiosity now.
A reminder of how we used to approach the problem.
Speaking of history, the next big step was Schuldes in 1945.
Schuldes, the master of the layered closure.
That was a game changer.
It really was.
It's known for its meticulous four-layer continuous wire suture technique.
Continuous wire, can you imagine?
It sounds incredibly precise.
It is. It takes a lot of skill and practice to master it.
So let's break it down.
Sure.
What are the key steps in a Schuldes repair?
Okay, so first, you start by dividing the fascia transversalis longitudinally.
Okay, got it.
Then you suture the lower edge of that divided fascia to the deep surface of the upper flap.
Using a continuous wire.
Right, that's the first layer.
Wow, that's already pretty intricate.
And that's just the beginning.
What comes next?
The second layer involves bringing the upper edge of the transversalis fascia down to the inguinal ligament.
Okay, so we've got 2 layers down.
2 down, 2 to go.
Bring on layer 3.
The third layer brings the conjoint tendon down to the inguinal ligament.
So we're basically reinforcing that whole area.
Precisely.
And finally,
Finally, we close the external oblique aponeurosis.
4 distinct layers, all with continuous wire.
It's a beautiful thing when it's done well.
It sounds like it takes a lot of practice.
Oh, absolutely.
Surgeons have to go through a whole apprenticeship to master it.
It's not something you learn overnight.
But the results speak for themselves.
That they do.
Recurrence rates of just 1 to 2%.
Which is incredibly low, even compared to some of the newer techniques.
It proves that a well-done tissue repair can still hold its own.
Absolutely.
Now let's move on to the McVeigh repair, also known as the Cooper's ligament repair.
Another classic technique.
What sets it apart?
The McVeigh is all about addressing the femoral canal.
So it's not just about reinforcing the inguinal ligament.
Right.
It's specifically designed to strengthen that area where femoral hernias occur.
Exactly.
And how does it achieve that?
By suturing the conjoint tendon directly to Cooper's ligament.
I see.
This direct attachment provides extra support to prevent those femoral hernias from popping through.
It's like a targeted reinforcement.
Exactly.
But, like with some Bassini modifications, sometimes you need a little extra help to reduce tension.
You're talking about a relaxing incision in the rectus sheath.
Exactly.
It's a common addition, especially when dealing with larger hernias.
It allows for a more tension-free repair.
Which is always the goal, no matter the technique.
Now, things took a dramatic turn with the introduction of mesh.
Yes, the mesh revolution.
Liechtenstein in 1984 really changed the game,
It was a complete paradigm shift.
moving away from relying solely on tissue.
And embracing the concept of a tension-free repair.
It must have been a big deal at the time.
It was a major advance in hernia surgery.
So what's the basic idea behind the Liechtenstein technique?
Well, it involves using a polypropylene mesh.
Polypropylene, that's the key, right?
It's strong, durable, and the body tolerates it well.
And they typically use a piece that's about 7.5 by 15 centimeters
With a special little slit in it.
for the spermatic cord.
Right, we don't want to be compressing that.
And this mesh essentially acts as a reinforcement patch for the posterior wall.
Exactly, it takes the strain off the tissues, preventing that tension that can lead to recurrence.
And it's secured in a very specific way, right?
It is. It's all about those fixation points.
Tell me about those.
Okay, so the mesh is fixed medially to the rectus sheath,
Got it.
inferiorly to the inguinal ligament,
Okay.
and superiorly to the conjoint tendon.
So it's firmly anchored in place.
Nice and secure, providing that broad support to the weakened area.
And the results have been pretty impressive, haven't they?
They have. Recurrence rates with Liechtenstein are less than 1%.
That's remarkable.
It's why it's considered the gold standard for open inguinal hernia repair.
It's the workhorse for a lot of surgeons.
Well, a good reason.
Now, following Liechtenstein, we had the development of plug-and-patch techniques.
Another step in the evolution.
How do they differ from Liechtenstein?
Well, the plug and patch was designed to tackle smaller defects.
So it's like a more focused approach.
In a way, yes.
And how does it work?
The idea is to use a mesh plug to actually occlude the hernia defect from within.
So you're plugging the hole, so to speak.
Exactly.
And then the patch part.
The patch is an onlay piece of mesh that provides additional reinforcement around the plug.
So it's like a double layer of protection.
That's a good way to put it.
And initially they used cone-shaped plugs, right?
Right, but there's been a shift towards using flatter mesh configurations for the plug.
Why is that?
Well, there were concerns that those cone-shaped plugs could sometimes migrate or cause problems.
So the flatter plugs are less likely to move around.
That's the thinking.
Makes sense.
Now let's talk about open preperitoneal approaches.
Preperitoneal, that means we're going behind the abdominal muscles, right?
Exactly. We're accessing the space behind the peritoneum.
Where the hernia is actually occurring.
Right.
And there are a couple of key techniques here.
There are. The stoppa and the rives are the main ones.
Let's start with stoppa, also known as GPRVS.
Giant prosthetic reinforcement of the visceral sac.
That sounds pretty intense.
It is. It's typically reserved for those really challenging cases.
The big complex hernias, the ones that have come back after previous repairs.
Exactly.
So what's the key to stoppa?
It's all about the mesh, the sheer size of it.
How big are we talking?
20 by 30 centimeters.
That's huge.
It's designed to cover the entire myopectoneal orifice.
So it's like a giant shield.
A big, strong barrier to prevent any further hernias.
Now, what about rives? How is it different?
Rives is also a preperitoneal approach.
But instead of that giant mesh covering everything.
Rives focuses on placing the mesh behind the rectus abdominis muscle.
So it's more targeted.
In a way, yes.
And the goal is still a tension-free repair.
Always.
Just in a different anatomical plane.
That's right.
Now let's move on to the minimally invasive revolution.
Laparoscopic hernia repair, a whole new way of thinking.
It's become so common now.
It's hard to imagine going back to the days before it.
So let's start with TAPP, the transabdominal preperitoneal approach.
One of the most popular techniques.
How does it work?
Well, we access the preperitoneal space through the abdominal cavity.
So we go through the belly to get behind the abdominal wall.
Exactly. We create a peritoneal entry, develop a flap, place the mesh, and then close the peritoneum back up.
It sounds straightforward enough.
It is in principle, but it does require a good understanding of the laparoscopic anatomy.
And there's always the risk of damaging something inside the abdomen, right?
That's always a concern anytime you're working inside the peritoneal cavity.
Now what about TEP, the totally extraperitoneal approach?
TEP-T, that's the one where we stay completely outside the peritoneum.
Avoiding the abdominal cavity altogether.
Exactly. No risk of bowel injuries or adhesions.
But I hear it's a lot more technically challenging.
It can be. It definitely has a steeper learning curve.
How many cases do you think it takes to really master TEP?
Some say 50, some say 100. It really depends on the surgeon and their experience.
So what makes it so challenging?
Well, it involves creating a working space in the space of retzius.
Which is the space between the pubic bone and the bladder.
Right.
And how do you create that space?
Through meticulous balloon dissection.
So you're basically inflating a balloon to create a space to work in.
That's the idea.
Sounds pretty delicate.
It is. It requires a lot of precision and patience.
And once you've created the space...
Then we can place the mesh.
And they often use self-expanding meshes for TEPIDE, right?
They do. They're easier to position in that confined space.
So with TEPA, it's a trade-off, right?
It is.
Less risk of abdominal complications.
But a more technically demanding procedure.
And a longer learning curve.
That's the balance.
Now, where does robotic-assisted hernia repair fit into all of this?
Robotics is a fascinating and evolving area in hernia surgery.
It seems like it's gaining popularity.
It is, but there's still a lot of debate about its true value.
In terms of outcomes, how does it compare to laparoscopic repair?
The current evidence suggests that they're pretty much the same.
So similar recurrence rates, similar complication rates.
Well, that's what the studies are showing.
So what's the appeal of robotics then?
Well, the proponents argue that it offers enhanced dexterity and visualization.
Because of those robotic arms and the 3D camera system?
Exactly.
So it can potentially make surgery easier for the surgeon.
Especially in those complex cases where the anatomy is distorted.
But the big elephant in the room is the cost, right?
Absolutely. Robotic surgery is significantly more expensive.
How much more are we talking?
It can be anywhere from $3,000 to $5,000 more per case.
That's a big difference.
It is, and that's a major factor that hospitals and surgeons have to consider.
So the question is, do those ergonomic and visualization benefits justify the extra cost?
That's the million-dollar question.
And it's one that we don't have a clear answer to yet.
More research is needed.
Now, let's shift gears a bit and talk about some special circumstances,
Okay, sounds good.
like pediatric hernia repairs.
Kids are a whole different ballgame.
How so?
Well, in children, we typically only do a herniotomy.
Yeah.
We just ligate the hernia sac at the internal ring.
And no mesh, no big reconstruction?
Nope. Kids usually have strong abdominal muscles, so they don't need all that extra reinforcement.
It's much less invasive.
Much less. It's usually a quick and straightforward procedure.
Now, on the other end of the spectrum, what about giant hernias?
Giant hernias, those can be quite the challenge.
They can be massive.
They can be, and they often involve a lot of redundant skin and tissue.
So how do you approach those?
Well, sometimes we need to use component separation techniques.
Component separation, what's that?
It's basically a way to mobilize more tissue to help close that huge abdominal wall defect.
So you're creating more space to work with?
Exactly.
And a common component separation technique is external oblique release, right?
Right. That's where we divide the external oblique muscle to gain more laxity.
And often they'll combine that with a panniculectomy.
Oh, yes, especially if there's a large panicence, that hanging abdominal fat.
So you're removing that excess tissue to improve the contour.
And to make the repair more durable.
It's like a 2-for-1. Now, what about emergencies?
Emergencies like an incarcerated or strangulated hernia?
Those are always high stakes.
Absolutely. Time is of the essence in those cases.
So how does your approach change in an emergency setting?
Well, the first priority is always to assess the viability of the bowel.
Because if it's strangulated, it could be dead.
Exactly.
And if it is,
Then we need to do a bowel resection.
remove the dead portion.
Right, and then repair the hernia.
And in those cases, they often use biologic mesh, right?
They do, especially if there's any concern about contamination.
Because biologic mesh is less likely to get infected.
That's the thinking.
It's like a safer option in a high-risk situation.
Exactly.
Finally, let's touch on some of the emerging technologies in hernia repair.
The field is always advancing.
What are some of the exciting new developments?
Well, there's a lot of interest in self-gripping meshes.
Self-gripping, meaning?
They have these little micro hooks that grab onto the tissue.
So you don't need to use tacks or sutures to fix them in place.
Right. Less need for fixation, potentially less pain for the patient.
Sounds promising.
It is, but long-term data is still needed.
And what about lightweight meshes? I've heard some buzz about those.
Lightweight meshes, they're designed to reduce that foreign body sensation that some patients experience.
Because they're thinner and more flexible.
Exactly.
So less bulk, less discomfort.
That's the hope.
And then there's robotics, which we talked about earlier.
Robotics is constantly evolving.
What's the next big thing in robotic hernia repair?
Single-port robotics.
Meaning?
All the instruments and the camera go through a single incision in the belly button.
So even less invasive than current robotic techniques?
Theoretically, yes.
It's like science fiction becoming reality.
It is, but single-port robotics is still in its early stages.
So it'll be a while before we see it widely adopted.
Probably.
Well, it's been an incredible journey through the world of inguinal hernia repair.
It has. We've covered a lot of ground.
From the early days of tissue repairs to the modern era of mesh and minimally invasive surgery.
It's a testament to the ingenuity of surgeons.
Always striving to improve outcomes for our patients.
Absolutely.
So as we've seen, there's no one-size-fits-all approach to inguinal hernia repair.
Each technique has its own strengths and weaknesses.
And the best choice depends on a variety of factors.
The patient's anatomy, their medical history, the surgeon's experience.
It's about making informed decisions based on the best available evidence.
And always keeping the patient's best interests at heart.
Thank you for listening to our podcast. See you in the next episode.